The integumentary system is your skin. So the very top layer, the part that you can touch, is epithelium, but immediately underneath is connective tissue. Both of those layers make up the integumentary system. So not just what you can see, the epithelium, but the dermis underneath. The epithelium is called epidermis, epi on top of. And it's probably the organ that, because it is our largest organ, it's the organ that gets hurt the most on us throughout our lives, right? It's external, it's waiting to get scratched, it's waiting to get bumped and bruised and maybe burned, putting something in the oven or, whatever, touching a heater. So it's definitely the one that we're all, I would say, fairly comfortable knowing a little bit about all of it. Okay, so I said this part. Epidermis is the stuff on top, the top that you can see, and the dermis is the connective tissue underneath. Here's some other things that are listed in the integumentary system because during embryonal development, they are actually part of the same layer, the ectoderm, and there's going to be invaginations during embryonal development that make them be created. So these epidermal derivatives, part of the integumentary system, hair, nails, your sweat glands that make the watery kind of sweat or the stinky kind of sweat, and then the sebaceous glands that can make our hair greasy. And the study of skin is dermatology. You probably knew that. You go see a dermatologist if there's something wrong with your skin. So that epidermis is like any other epithelial tissue. It is avascular. It has a top and a bottom. It does have nerve supply. You can feel the 2-millimeter spider walking amongst the hairs on your arm, right? Before you freak out. It doesn't bleed because there is no blood. What the heck, Dr. Wiggins? If I get a cut, I bleed. The epidermal layer is epithelium. It does not have any vessels going through it. So when you look at them under the microscope, you're not going to find any capillaries. But if you go deeper than your epithelial layer, deeper than your epidermis, you're in the connective tissue layer. And that's going to be where the blood vessels are. That dermal layer actually has 2 different kinds of connective tissue, and we'll get to that in a little bit. Now, hypodermis, hypo below dermis, isn't perfectly part of the integumentary system, but we don't have another place to put it. It's that fat layer kind of that's between your integumentary system and the deeper stuff underneath the muscle. So most of it's fat. The hypodermis sometimes is called the subcutaneous layer because your skin is your cutaneous membrane. So your hypodermis is hypodermis, but also subcutaneous below the cutaneous membrane. Cool picture, lots of things to look at on this, showing different kinds of glands. So this right here, this right here, right here, right here, these bumpy glands are sebaceous glands that can make a little bit of grease on your hair. This is a sweat gland that you're used to, if you go outside in Texas, you know exactly what I'm talking about. This layer right here is a very thin layer of connective tissue called the papillary layer right there. And then deep to that, the majority of the dermis is going to be reticular layer. So this papillary layer is part of the connective tissue, part of the dermis. It's very thin and has lots of fine, tiny, tiny capillaries. But as we get deeper into the dermal layer, that's where we're going to get bigger vessels pretty far down deep. Here's that subcutaneous layer with all the fat. And then we have sensory nerve supply. So this right here is called a Pacinian corpuscle, but it's also called a lamellar corpuscle. If you look in your lab book, it's called Pacinian, and it kind of looks like an onion cut in half. And then we have free nerve endings that are going to come up and touch right there at the epithelium so that you can feel the spider. And what else? Sweat pore. So there's the sweat gland that's coming out to the skin. Okay. The epidermis is stratified squamous epithelium. So I said it's a thin layer, but it is multi-layered. It's just that it doesn't take much of a scratch to make you bleed, right? Just to get an idea. You know, if you pass by a rose bush and you have like a white line, but it's not bleeding, you felt it. It didn't feel good, but it doesn't open up and bleed. You just went through the epidermis. But most of the time, you know, when you snag by a rose bush, are you not going to bleed? Probably. So it doesn't take much to get through that epidermis. But that being said, it has layers, and we're going to go through those layers. The name of your skin cells are called keratinocytes because this stratified squamous epithelium produces a protein called keratin, and that keratin has protective properties. Like any other epithelium, it's going to have some tight junctions and desmosomes. Remember, the tight junctions are at the apical surface. Desmosomes are like zippers on the side of the cell to keep those cells stuck together. And we lose millions of skin cells every day, but that's okay. When we have a brand new skin cell formed at the base of the layer, so I'm going to show you that in a minute, that guy is going to be gone in a month. So they have about a 1 month life. Oh, there we go. So besides the keratinocytes, we also have some melanocytes, and that's what makes the color of our skin. So those guys are different for just about everybody. We all have different shades of skin. The more melanin you produce, the more dark you are. So it's not that we have different numbers of melanocytes, it's just that some of our melanocytes are busier than others. They like to live in that deep base layer of the stratified squamous. So they're sitting at that basement membrane right above the top of the dermis. What will happen is those melanocytes, although they live at the bottom, one of the things that the Golgi body packages up as a protein is melanin. So that melanin is going to exocytose and go into the next layers and work their way up. Their job, the melanin's job, is to protect us from UV damage. So white people have a tendency to get a lot more wrinkles than black people because black people are much better protected from the sun than we are. Also, white people have a tendency to be more prone to skin cancers because of this, because of the UV damage that we sustain during life. And so the darker you are, the more protected you are from damage from the sun. Another cell that just kind of patrols around the epidermis is so cool. It's a macrophage, and he's got a name. He's a dendritic cell. He has another name, Langerhans. I like the term dendritic cell for memorization because that's definitely the term that we're going to use when you get to A&P2 and we start talking about immunity. We talk about dendritic cells. So these are macrophages that are always patrolling the epidermis. Macrophages' job is to clean up any sort of debris or try and ward off any invaders. They eat them. They're macrophage. They eat things. Phage. Phagocytosis. Also in the deepest layer, we have some cells called Merkel cells, and they're another kind of cell that is going to feel that little spider. So those free nerve endings that I showed you that were in the dermis that were heading up to the epidermis, their target is these guys, these Merkel cells. We also have some different kinds of sensory nerve endings that almost bundle up, and they're called Meissner's corpuscles. those guys are going to be in the dermis. So we've seen Pacinian corpuscles, Merkel cells, and Meissner's corpuscles now. This is a picture of melanocyte, and you can see that he's packaging up little packages of melanin, and they're going to exocytose out the cell and work their ways to the next layer so that each cell gets the color. He's living on the bottom layer though. The stratum basal, let's go ahead and throw that out there. There's multiple layers to the epidermis, but the basal is the bottom layer. The stratum basal is where we have the stem cells that are doing mitosis. So we're listing all the layers here, depending if it's thick skin or thin skin. If it's thick skin, we have 5 layers. If it's thin skin, we have 4 layers. Thick skin is only going to be on the palms of your hands and the soles of your feet. So the underside of your hands and the part of your feet that you walk on. So the 5 layers starting at the bottom, the one I just said, stratum basal. So if we're at the base, stratum basal. The next layer is stratum spinosum. The next layer is stratum granulosum. If you have thick skin, or if we're talking about areas of thick skin, then the next layer is stratum lucidum. If we're talking about thin skin, there is no stratum lucidum. And finally, the part that you see and feel is stratum corneum. So this right here is showing all 5 of the layers plus the dermis. So right here is the bottom, the stratum basal. It's 1 cell layer thick. All right here. And this 1 cell layer thick is where the basal cells, or what they're called, they're stem cells. So they're going to go through mitosis, and when they double, one of those guys is going to stay in place, and the second daughter is going to go to the next layer and work their way up. So this right here, this is thick skin, so you can tell that this right here is all the stratum corneum. So many cell layers thick on thick skin. One of the reasons it gets its name. Here's the layer that thin skin doesn't have, right here, stratum lucidum, right there. Stratum granulosum, right here. Stratum spinosum is underneath it. All that. And then when we get to the dermis, here's the connective tissue. So a very thin layer right here called the papillary layer is areolar connective tissue. So that's what it's made of. It's made of areolar connective tissue, and it's called the papillary layer. Then this part with all the swirly whirlies, remember from the connective tissue, this is dense irregular connective tissue right here, and that's going to be called the reticular layer. I'm not in charge of naming these things. I'm just telling you their names, because it seems like if it was the reticular layer, wouldn't it be reticular connective tissue? But I don't know. Okay, so here's a drawing showing that stratum basal right there. So this is all where this mitosis happens. And remember, in the stratum basal, that's where we have melanocytes are living, and we're going to have, there's one right there. He's going to make little vesicles of melanin, and that's going to work its way up into those cells right there. This is one of those tactile cells that's getting the information from, so it's the target of a free nerve ending right there. Here's another melanocyte right there. Here's a dendritic cell. He's the macrophage that I was talking about that patrols the epidermis. So the stratum basal, very important. These guys are stem cells. These guys are the guys that are giving you your new skin. So from the point of making a new daughter to the point of sloughing off of your body is approximately 30 days. When it goes through mitosis, one daughter is going to stay in the stratum basale, the other daughter is going to work its way up. And again, the stratum basale is where the melanocytes live, the guys that make coloring. Stratum spinosum gets his name because when he's stained, it looks like he has prickly spines. So at this point, they're not basal cells anymore. They're not stem cells. Basal cells are a type of stem cell. Now they're going to actually be called keratinocytes. So when the daughter leaves the stratum basale and starts working its way up, she's made it into the stratum spinosum layer, and lots of melanosomes in there and lots of dendritic cells in that area. This layer is kind of thick. So the stratum basale layer is just one cell layer. This guy's got more layers. Stratum granulosum, he gets his name because this is when we're starting to get a granular appearance because keratin is going to start to happen now. So we're going to have some Golgi apparatus building little vesicles full of the protein keratin. So it gets a granular layer with stain. It's a pretty thin layer. The cells are starting to flatten, and honestly, the organelles are starting to die out. The keratin is going to start to take over that area, and the organelles are going to start to die out. They're starting to get a little bit too far away from the capillaries, starting to get a little bit less of the nutrients from the blood from the papillary layer. Again, stratum lucidum is only going to be in thick skin, so soles of your feet and the palms of your hand. And it's kind of an oily solution, so it doesn't, an oily protein, and so it doesn't take up stain very well. So you can see on that previous histology slide, it's kind of clear. Then the top layer varies in thickness. So if you're talking about thick skin on the palms of your hands or the soles of your feet, it's pretty thick. Stratum corneum they're all dead now. No nuclei left, and as a matter of fact, sometimes you can hardly see anything for all the keratin in there. It just looks like a bunch of purple. But still has a function, right? It's still epidermis, so you still have tight junctions, and you have desmosomes, and it's all zipped up together, so it's acting like a barrier. You know, when you get rained on, the water rolls off, it doesn't absorb into your skin. So a barrier of lots of different things. It's going to help protect against cooties, thanks to the dendritic cells, the macrophages in there. It actually has what's called an acid mantle. So slightly acidic pH of the skin secretions help to prevent bacteria from growing. And then physical. They're all tightly bound up together. And also we have some glycolipids that are in there that allow for waterproofing. Okay. When a cell goes through cell death, and that's programmed, that's what it's supposed to do, that's called apoptosis. So we lose 50,000 cells every minute. That's a lot, right? That's millions a day. Here's histology of the difference between the stratum corneum of the thick skin versus the thin skin. So look at that stratum corneum right there. That's lots and lots and lots of cell layers, as opposed to this right here. This is just most of your skin. Okay, let's talk about the dermis. So this is immediately under the epidermis, underneath the epithelial layer. This is connective tissue, and there's two kinds of connective tissue. A very thin layer of areolar connective tissue, and that's called the papillary layer. I've already said this. And then underneath here is the swirly whirlies, which is dense irregular connective tissue, and his name is the reticular layer. We've got some hair follicles embedded in this area, sweat glands, sebaceous glands, bigger nerve vessels. So the papillary layer has pretty fine capillaries, but the bigger ones are actually embedded deep in here in the reticular layer. The superficial layer of that papillary layer, so we've got areolar connective tissue, so it's a looser connective tissue, fine little capillaries, little free nerve endings, some Meissner's corpuscles for feeling. And this also, you can see how it kind of goes up. That's how it gets its name, papillary layer. And on thick skin, it's how we get our fingerprints. Another name for them is friction ridges, where the papillary layer goes up and down. Reticular layer, dense irregular connective tissue, swirly whirlies. Remember, the pink is collagen, does have some elastin fibers, because if you pinch on your skin, doesn't it pop back to the regular position that it was? We've got those Pacinian corpuscles are deep, and they help you feel pressure and vibration. If you cut deep into the reticular layer, you're going to bleed a lot more than if you just cut the papillary layer. These vessels are bigger. We're going to start to get some pockets of adipose tissue at this point because we're getting really close to the subcuticular layer, or subcutaneous layer. Okay, let's talk about these cleavage lines in here. So we have those swirly whirlies, and we have the swirls are collagen fibers, right? They're pink. You can't really see them, but they're important for surgeons because you want to make your surgical incisions through parallel to these lines because it'll heal better. So this is what a surgeon would need to know, is all of the directions of these fibers. This is true for dogs and cats too. And when you cut parallel to the incision, it just heals better. Less tension on the actual cut itself, so when you close it, there's not the pull from the collagen fibers because they're going in the opposite direction, as long as you go parallel. Less likely to come apart, and it's going to heal prettier with less scarring. Don't memorize the directions of these of these bundlings, but you do need to understand what these lines of cleavage are for, and things that I just said, better healing, important for surgeons to minimize an incision from coming apart, but don't memorize the actual picture and the direction. I'm not going to ask you that. What's a stretch mark? A stretch mark is when your dermal layers tear, so not just your epithelium, because that heals well, right? So they're called striae. A blister is when you've had trauma to skin and your epidermal and your dermal layers separate. So your body's going to fill it in with fluid. You should leave the top of the blister there because it's allowing healing, and it's keeping cooties from the outside world from coming into your blister. It's more likely to get infected. Those are striae, so tears in the dermis. Cool picture, I love pictures. Okay, so let's talk about skin color for a second. We've already mentioned melanin. So melanin is very protective of UV radiation. We all have basically the same amount of melanocytes, but some of them are busier than others. Some of them make more color. So, we're genetically, we have a certain amount of pigment to our skin. Of course, an albino doesn't make melanin, right? So they're extremely prone to UV damage and cancers. So how do we get a suntan? Well, when you go outside and you sit in the sun, your skin cells are like, hey, getting beat up here. Can you ramp it up a little bit? And the melanocytes will produce more color. But the thing is, it's temporary, right? Because in a month-ish, the skin is going to come off. So unless you just stay in the sun and you keep sun tanning, you're going to go back to your normal genetic color. We actually have different colors of melanin. Some of them is in the brown family, and some of them are in the reddish-yellow family. What's a freckle or a pigmented mole? Well, those are areas of accumulation of melanin. So also freckling is a genetic thing. So what happens? What else happens? What else happens if we go outside in the sun too much? Our elastic fibers don't do that stretching and snapping back wash after wash thing anymore. They start to clump up and the skin gets leathery. Another thing, UV light destroys folic acid. This is terrible if you're pregnant. Especially that first trimester, you must have a normal amount of folic acid for DNA synthesis. And if you don't have it, you're very likely to have birth defects in that baby. You probably have heard this before. Some drugs lead to photosensitivity, so more likely to have sunburns. So certain antibiotics, certain acne medicines, certain antihistamines. Here's another color, carotene. Carotene is yellowish, orangish, like a carrot, you know? But if babies eat lots of carrots or lots of sweet potatoes, you're going to notice that carotene color coming out in their skin, especially the palms of their hands and the soles of their feet. Hemoglobin is a reddish pink. So heme is what carries oxygen inside the hemoglobin molecule. And so on very fair people, it's easy to see them flush as you have a rush of blood coming to the face. You can actually see the hemoglobin. I love to ask fill-in-the-blank questions on these. Cyanosis is blue. If somebody is not getting good oxygen because of heart failure or because they're very, very cold, they will get cyanotic. So they'll get blue lips, maybe some blue to their gums. The term pallor means they're pale. Somebody's paler, they have a lot of pallor. And so this can be from low blood pressure, whether it's, fixing to faint, you can see all the color washed out of their face. Okay, that's pallor. Anemia is another one. You can tell that the skin's getting kind of blanched from anemia or mucous membranes, so your gums. Erythema, this is like a rash. It can also come with fever, so it's a reddening, inflammation, allergies. And then jaundice is yellow. That can be something going on with the liver because you're seeing bilirubin. Jaundice is bilirubin. And also red blood cells have bilirubin inside of them. So if red blood cells are breaking, hemolysis, you'll see jaundice. Two different reasons for jaundice. Not just liver. Okay, bruising. What's that? That's when you actually bleed under the skin. You don't break the skin, but you get a blood clot underneath the skin, which makes sense, right? Because when you get a bruise, it's a big old slam. And so as the blood clot starts to dissolve, it becomes less purple and it becomes more yellows and greens as the body cleans it up. Those little macrophages are coming and cleaning up that blood clot. The brown or black necklace around the neck, that hyperpigmentation, sometimes it's also in the armpits. This can sometimes indicate uncontrolled diabetes. Hair, again, is an epithelial derivative. So during embryonic development, that layer that's going to be skin is called ectoderm. It invaginates, so it dips down and kind of creates a tunnel into the dermis. But if you look at the layers around the hair, the layers that are going to create the hair, it's all the same. It has a basement membrane, and you've got stem cells that are going to be producing the cells that make your hair grow. And it's just kind of dipped down into like a sac, an invagination. So hair is all dead keratinized cells. I love the first function, warn of insects on the skin. You know, I guess that is kind of an important thing if it really is a venomous something or whatever, but this is number 1 on the list. Anyway, your hair actually helps protect your scalp from physical trauma. It protects you from heat loss. So, 90% of your body heat is lost through your head. So wearing a hat in wintertime genuinely helps immensely. Of course, if you wear a hat in the summertime, like if you're a construction worker, you can feel the pain, how hot you get. So it's going to be like your own little built-in hat. And then, of course, it does help shield some of the skin from sunlight. So those dips, those invaginations, are your hair follicles. This keratin that these keratinized cells, this is going to be a different sort of keratin. It's this protein is going to be a lot harder than the ones that's on your skin. And these guys don't flake off. So it's a modified type of epithelium from your skin. It does still have melanocytes, so that makes your hair color. And then, of course, when you have gray hair, what's happened is the melanocytes are producing little empty vesicles. And those empty vesicles is actually what's making your hair stiff when you have gray hair. So gray hair definitely is more wiry, and it's because you have all these empty air vesicles that don't release anything, because melanin vesicles release the melanin into the actual cells, but there's nothing to release. So hair gets wiry, stiff compared to non-gray hair. Just like skin, we have different shades of melanin. So in the yellow family and in the black family. Okay, cool picture. I want to show you a couple of things. In a lot of things in anatomy, we're going to have an outside, which is a cortex, and an inside, that's a medulla. So on this hair right here, we've got this term cortex right there. And it's pointing towards this part right here of the hair. And then a medulla is the inside. So we're going to have, in the kidney, we're going to have a cortex and a medulla. You've probably heard of a bone. Now we have a cortical bone on the outside, and then we have a medullary cavity on the inside. So this is the medulla right here. Anyway, this is going to be the basal cell layer that's making, so this first layer right here, first layer, where my pointer originally started, right here. That's going to be the basal layer that's going to be producing the hair, a single layer, and where the melanocytes are anchored to, and they're going to be making the melanin and release their little packages of melanin up into the hair cells above. If you ever yank your hair out and you see a little white layer, this right here is what you're seeing. All of this. And of course, if you yank a big old chunk, it's going to bleed. That's because this is the connective tissue underneath the epithelium where the blood vessels are. So that white part that you get yanked on sometimes that's the cuticle of the hair. So we have different kinds of hair names. We have vellus hair, which is really fine hair that you see on women. We're all mammals, and we have some fine hair on our face. Children have fine hair all over them. That's vellus hair. Terminal hair is going to be coarser and longer. So what's on your head, what's on your eyebrows, and of course, as we reach sexual maturation, men's going to have it on their face and their neck, armpits for all of us, pubic areas for all of us. Nutrition definitely affects hair growth. Good nutrition, good hair. Poor nutrition, not good hair. And this is true across the board with any animal. And then hormones affect hair growth. However, you will definitely notice that different people have different cycles of hair growth. So some people might say, oh, I can't grow my hair past this length. Well, that's probably true because their cycle is faster, so their hair falls out before it ever has a chance to get longer. They're making more hair, but everybody's different. This is a great fill-in-the-blank question. Alopecia. So alopecia is when your hair starts to thin in certain areas. It's just something that happens as we get older. It's normal. Baldness is when you, not just thinning, but you actually, the hair follicle quits making hair. And definitely more common in men. And then there's definitely a genetic predetermination to people that have true baldness. Okay, so sometimes our hair gets thin because of other reasons, like or maybe thick, hormonal changes, and then you have the baby and you're nursing the baby, your hair all falls out. So your hair is beautiful when you're pregnant and it starts to, you find clumps of on the floor after you have the baby. It's just from hormonal changes. That is, growing a human being inside of you and having a baby is definitely a stress on your body. It's normal, but nonetheless a stress. Crash dieting, so poor nutrition, also shocking your body. Surgery, sometimes certain drugs even will make your hair thin, but it'll come back. Hypothyroidism, when your thyroid's not working quite right, hair definitely gets kind of a thin, limp look. This is a cool thing. If you ever wondered why your hair is the way it is. So those hair follicles that your hair is sitting in, this guy right here, is it a really tiny hair follicle or is it a really wide hair follicle? If it's a really wide hair follicle, your hair is going to be thick. If it's a really skinny hair follicle, it's going to be thin. Now, here's something else. What if it's not round or oval? The flatter it is, the more shape you're going to have to that hair. So if it stays a fairly round shape, you're going to have straight hair. But the more ovoid it becomes, so oval in shape or even squished, then the more curves you're going to have in your hair, to the point that if your follicles are really flattened, you're going to have like tiny spirals. Nails are also an epidermal modification. So from the epidermis, they're going to have that same growth pattern. Your book gets into more information than I care to. So I just have these two top ones in normal size font. So your nails protect the ends of your fingers. You're always using your fingers to pick things up. And then also it kind of acts like a backboard to make it easier to pick things up. So protective, but also makes it easier to use your fingers and to grab things. more information than you probably ever want to know. Okay, let's get into some diseases. So if you can use nails and skin to get started on a physical exam before you ever pull out any sort of fancy toys. If you have something where your nails, you look down at nails and they're yellow tinged, that could be a respiratory disorder. It can also be a thyroid gland disorder, but I encourage you to look at the fingernails of somebody that you know that's a chain smoker. Look at their fingernails and see if they're yellow. It's not from the tobacco, it's from poor oxygen exchange. We all probably know somebody that has thickened yellow toenails. That's usually due to a fungal infection of the nail. Fungus is hard to get rid of, so if you ever start to notice a change in your toenail, I recommend going to the doctor right away and nip it in the bud before it ends up being the whole toenail, because it's very hard to get fungus under control. It weakens the toenail, and it has a tendency to fall off, regrow, but then it's never normal. A spoon nail, so the nail actually kind of looks concave. That's an iron deficiency. Bowes lines, this is when you have horizontal lines going across your nail. So it doesn't tell you exactly what it is, but if you have horizontal lines going across your nail, it's worthy of going to the doctor. Now, vertical lines, no problem. That's just a normal growth thing that happens sometimes. This is a picture of a spoon nail. Okay, sweat glands, another epidermal derivative. We have Merocrine sweat glands, so these are the kind that are going to just release their product in little vesicles, and they're going to exocytose out. And these are going to be the general sweat glands that you think of. You're hot outside and you've got a damp brow, a damp upper lip, your arms are damp. That's going to be these guys. These are Eccrine glands. Apocrine glands are the ones that we think of as the stinky glands. So these also behave as a Merocrine gland. So both of these are not holocrine glands. These are the kind that release their materials through exocytosis onto a surface. But apocrine glands, the stinky glands, are the ones that you think of, like armpits and private areas that get a little smelly. These eccrine glands, the sweat glands that are just all over, obviously are the most numerous. So you actually have more on the palms of your hands, the soles of your feet, and your forehead than anywhere else. But of course you have them on your arm, and you've probably noticed maybe from the sides of your heads dripping sweat, your upper lip. These guys' job is to cool you off. And what's mostly in sweat is water. But we're salty people. Sodium is a high concentration on the outside of cells. Sweat is not cellular. It's just extracellular stuff. So a lot of water and some salts. It does have some a pH, an acid pH that helps protect your skin from bacteria, and but it's not cellular. Okay, so the stinky sweat glands are called apocrine glands. The secretion is not just water and salt so much. It actually has some proteins and some fats in it. And what happens is bacteria start to break down those substances, the fats and the proteins. And that's where the smell comes from. It's a little bit thicker, so it's not as watery, and might be a yellow color, might be a whitish color. These guys, instead of dumping directly onto the skin surface, they go into hair follicles, and they don't work until you hit puberty, so they are not functioning until, hence the stinky teenager. We have some modified apocrine glands. So ceruminous glands are in your ears that make earwax, and then mammary glands make milk. Okay, these guys are the guys that make your hair oily, sebaceous glands. And they're everywhere, except on the palms of your hands and the soles of your feet. So if you see a model and you see these big, they almost look like flower rosettes, and they're dumping into a hair follicle, those are sebaceous glands. These guys are going to be holocrine secretion. So I mentioned this in the section that we did glands. These guys the whole cell is going to break, and that's how it releases its product. It doesn't empty it out onto a surface through exocytosis. This guy, the whole cell breaks. But that's okay because it's an epidermal derivative, so you'll make more. Remember? Epidermis, very regenerative. This guy also has a large amount of bactericidal properties, and that oil helps soften your hair and your skin. One of the reasons that we're not supposed to wash our hair excessively. Homeostatic imbalance, acne. Those sebaceous glands that I just talked about, they get inflamed. Maybe they get blocked. Maybe the duct actually gets blocked. And so they'll either become cystic, so full of material that's not infectious, or you can have pustules. And actually, pus can be infected or non-infected. So in other words, it can be sterile or non-sterile. And if it's sterile, then your white cells put out a purulent exudate, but there's no bacterial cause. It's just from inflammation. Seborrhea. Seborrhea is dandruff in adults. In children, it's cradle cap, and just looks like yellow-brown flakes. And this is from the sebaceous glands being overly active. It doesn't look kosher, but it's really nothing to worry about. It's extremely common in infants, and you just make sure you follow the doctor's orders as far as how often you bathe and how to bathe that infant. Adults, we have shampoos that help with that to calm down those sebaceous glands. There's cradle cap, also known as seborrhea. Seborrhea is an excellent fill-in-the-blank question. Okay, functions of the skin. Protection, that's a biggie. We're going to do more on that. Body temperature regulation, cutaneous sensation. It has metabolic functions. And here's one that we didn't get into that first week of school or the second week of school when we did the body systems, a blood reservoir. So let's do the protection. There's 3 different kinds of barriers that the skin does. It's a chemical barrier, it's a physical barrier, and it's a biological barrier. As a chemical barrier, sweat has antimicrobial proteins, and also it has a lower pH that's going to help minimize the ability for bacteria to multiply on your skin. We have bacteria everywhere. We've got bacteria on door handles and the top of your desk and all over your computer, and this skin is going to have a different pH that's going to prevent them from going crazy with multiplication. The melanin is a protein that's a chemical barrier against UV radiation. So the darker you are, the more protected you are from the sunlight, from getting cancer from that. And then we also have antimicrobial properties through a protein called defensin. Again, our cells are stuck together by tight junctions. And that, along with some glycolipids that are attached to their cell membranes, that's going to make your skin fairly waterproof. So rain hits your skin, it just rolls right off, right? Some chemicals can get past the skin, right? So again, lipid-soluble substances, you have to be careful. They can absorb into your skin, and these kind of things will usually have a warning. Wear gloves. So especially if you're like working in the garage, auto mechanics and such, they have some organic solvents that they really need to be careful with because you don't want that kind of stuff absorbing into your body. Some plants can actually get through your skin, like you've probably poison ivy, poison oak. They can actually, their product is oil-based, so it can get through your skin. Some other dangerous things are listed here. Heavy metals, certain drug agents. So some drugs are meant to be put on your skin and be absorbed, right? And the way that they do that is they mix that drug in with some sort of agent that easily crosses the skin. So some things can get past the skin, and so some things we must be careful. And usually they're going to be an oil-based substance that can get past those phospholipid tails. Biological barrier, I mentioned those dendritic cells in the epidermis that are patrolling. We'll get more into those in AMP2 when we do the immune system. But then the dermis underneath, it has its own macrophages. So dendritic cells are the names of the macrophage that are specifically in the epidermis. You'll find that we have macrophages all over our body, and some of them get special names. Some of them just get called macrophages. A macrophage is a white cell that eats things, phagocytosis. So dendritic cells are specifically macrophages that are hanging out in the epidermis. Okay, body temperature regulation. Your book goes into the details of insensible perspiration and sensible. Sensible is the one that you think of to cool your body. And I'm not going to ask you a question about that on the test, but it could show up on your final, so I included it here. Okay, so if it is really cold outside, your blood vessels are going to tighten. And what that does is it slows heat loss by pulling them. When they constrict, they're pulling further away from the surface. So when they pull away from the surface, you lose less heat. When you're hot, those vessels dilate. So they're going to be closer to the surface, so that can help you lose heat from your blood. We have sensory receptors inside of our skin that help us know what's going on the outside, such as temperature, but also touch and painful things, so you can get away from whatever's hurting you. Metabolic function, can't say this enough. You have to have vitamin D in order to absorb your calcium. Milk is fortified with vitamin D so that the calcium in your milk will do some good. Caltrate, which is a calcium tablet that women take once they hit 40, or men with calcium problems. It's not just calcium, it's also vitamin D, to make sure that that calcium that you put in your mouth, that supplement, is going to do some good. So there's lots of different things that can happen to your skin, and some of them are pretty common, including all the boo-boos that you get a little infection and stuff. But more serious than the usual day-to-day bump, scratch, cut, whatever, is cancer and burns. When we say that a cancer is benign, that means he doesn't spread anywhere. He doesn't go to your liver. He doesn't go to your lungs. He doesn't go to your bone. And those are very common types of skin cancers. They're usually like a keratitic plaque. What causes these kind of things? Overexposure to the sun. So, especially if you're fair-skinned, you have a lot more protection if you're darker skinned from the radiation of the sun, because that's what it is. It's radiation. If you have had repeat sunburns, you are more prone to skin cancer. The three major types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. Basal cell is the most common and the least dangerous. Melanoma is not that common, but he's got triple stars on here because he is definitely the most dangerous, and you could save a life if you see a melanoma on somebody and you tell them and let them know. So the basal cell carcinoma is going to originate from the basal cells in the skin. You cut it out and no worries. Now, if you let it sit there forever and ever and ever and ever and ever, can it spread? Yeah, eventually. But most of the time, people will get a little alarmed when they have something growing on their skin and eventually go get it off. This is an example of a basal cell carcinoma. Squamous cell is the second most common type. He's very slow growing. He's going to look reddened at first and scaly, maybe even occasionally bleed. But he can metastasize. He can spread to your chest and kill you. So the goal would be, if you see something not right on your hands or your face, go get it off. This is an example of a squamous cell carcinoma. Okay, melanoma. This is when the melanocytes go rogue. He spreads to your brain. He spreads to your lungs. He spreads everywhere pretty quickly. So if you have an area, let's say a mole that's kind of changed, it's been sitting there forever, and all of a sudden it starts to get a different kind of shape that's not symmetric anymore. So the borders are irregular. Coloring doesn't match. So what was all brown now has chunks of black in it. It can be different colors besides black, but melanoma is usually considered a blackish type growth. If they don't have color, that's usually, and it turns out to be a melanoma, that's a huge worry, because that means that that cell is dividing so fast it's not even developing melanin inside of it. So in other words, it's multiplying so fast it's not even getting coloration to it. That's pretty big. I would be worried for this human being. That's probably already spread somewhere. Why would you not go to a doctor before it got this big? IDK. So burns, we always think of burns as being fire. There's actually other kind of burns that you can get. Radiation is actually a type of burn. Of course, acid is a type of burn. Electrical shock, that's a type of burn. So what happens is those proteins get denatured. Remember that question from the first exam? They get destroyed. That's going to destroy the cell. You have proteins embedded in your phospholipid layer. You've got all kinds of proteins on the inside of your different cells. You have a bazillion and one different proteins. So excess heat is going to denature those proteins. You know, what was a tertiary shape becomes a primary shape, and then pieces start falling off of it. So the immediate threat to a burn is dehydration. No matter what kind it is dehydration. You have damaged epithelium. And here we go. On the inside, if you breathe in chemicals, caustic chemicals, that actually burns your epithelium of your respiratory tree. It kills that pseudostratified ciliated columnar, and if it gets deep enough, it'll kill that simple squamous where you have gas exchange. Instant death. So the immediate threat is just rapid dehydration. And when your skin starts to ooze, let's go back to skin. Your skin starts to ooze, you're not just having the water leave, but you're going to have anything else that's extracellular. So sodium and chloride, and if you've killed a bunch of cells, potassium. So you're going to lose lots of different things. So without that water and the correct electrolyte balance, your organ systems start to shut down. So kidneys and heart, you're going to die. Infection's next. So the first concern is dehydration. So if I put this test question on your test, what is the first top concern with a burn? It's dehydration. And then you can list other things if you want, but if you don't put dehydration as number one, the answer's wrong. Infection is next, but that's going to be a day to 3 days later. So when we evaluate how serious a burn is, we use something called the rule of nines. We're going to section the body out, and we're going to do 9 or multiples of 9 to determine how much fluid is lost. So, and I'll show you a picture of that in just a minute. First degree burn is like a sunburn that doesn't even blister. It hurts because you have nerve endings in your epidermis, right? Because that's epithelium. But it's just first degree. It doesn't even go into the dermal layer. Second degree, it actually got into the top part of the dermis, so in the papillary layer. And what's going to happen is the epidermis and the dermis are going to separate, and you'll build a fluid pocket between the epidermis and the dermis, and that's a blister. A third degree is a full thickness burn, so you get through all of the epidermis and all of the dermis. And that skin is going to first turn like a gray color, and then it's going to go white, and then it's going to go black, and then it's going to fall off. So with a third degree burn, it's not even as painful as a first or second degree burn because you've killed everything. You've killed the nerve endings. You might have even gotten it down to the bone. So if you char bone, that's a fourth degree burn. But when you do a third degree burn, if it's not too much of your body and you live through it, then you need a skin graft. So first degree burn, just some redness like here along the finger. So I'm guessing he put his hand on hot something. Could be chemicals, but anyway, just because of the placement. This blistering right here, so it actually got into the dermis. So there's a fluid pocket where you've separated your epidermis from your dermis. Third degree, it's whitish. It's going to start to turn kind of a black color and fall off. So if you are 30 to 40% body coverage of a burn, you could die. Now, if you are attended to straight away and they get an IV in you, you can live. But without treatment, 30 to 40%, you're going to die. So obviously the first treatment is going to be the IV fluids because I've mentioned that a lot. But then we have to take care of, we've kept you alive, now what? We've got to keep you from getting infected. So we've got to continuously clean that area. So debride that area is removing that charred tissue. That's not good anymore. So we're going to help the body along and keep it clean and put bandages on it and change those bandages frequently. by-mouth antibiotics because you have broken the barrier that keeps the outside world out. And then if necessary, you're going to put skin grafts on it, because if you don't have anything alive to meet an edge-to-edge healing process, you need to get a tissue from somewhere. Usually it's going to be an autograft. I did this already, but we'll do it again. Chemicals, acids, bases, chemotherapy. Chemotherapy does burn. So, maybe you get some vomiting and diarrhea because it killed the lining, the mucous membranes, that simple columnar of your stomach and your small intestines. Fortunately, it'll come back. Electrical frostbite. Frostbite is a cold burn, right? Friction is a kind of burn, so like a rug burn, that's a burn. And then radiation. So here's an example of the rule of 9. So when you put these things together, then you're going to figure out what the total percentage of your water loss could be. So your front of your head, 4.5%, the back side of your head and your neck, 4.5%. So your whole head, 9%. The front of your limbs, the back of your limbs, 9%. Front of your limbs, back of your limb, 9%. 9 plus 9, 18. Your trunk, the front of it, 18%, the back of it, 18%. Your limbs, 9% on one side, 9% on the other side. So a total of 18 and 18. And then your perineum, 1%. Okay. So again, 30 to 40% without treatment, you're going to die. A decubitus ulcer can happen in a lot of places, but a bed sore is a pretty common skin lesion that happens from not moving around. So you have all these bony prominences, and you know them. You've seen people with hip bones and vertebrae and such. And wherever you have a bony prominence, you have less padding, right? And so if there's less padding and you're laying on that area, you're putting pressure on that area for a long time, you're blocking blood flow. And so what's going to happen is those areas that get no blood flow, the skin dies, the tissue dies. So then you get a sore and it gets infected. So the treatment is just to turn people. So this would be somebody maybe that's had some sort of injury that they have to stay in bed, senior citizens, maybe somebody that's paralyzed, somebody that needs help, especially a quadriplegic. They have to be turned pretty frequently. So a decubitus ulcer is the general term of these sores, these pressure sores. And the most common place is actually over the sacrum area. A keloid. A keloid is an overproduction of scar tissue. So for this person, maybe this person got her ears pierced. Hers or his, but whatever. Anyway, and because you have created a hole that's not usually there, most of the time that hole is just going to heal up and you can continue to put an earring. But sometimes you start to get this overproduction. It's called hyperplasia of scar tissue. And this has a tendency to have a genetic link in people with darker skin. So y'all are free from, if you've got darker skin, you're free and clear for the most part from a lot of skin cancers, but keloids, which are a lot less of a big deal than skin cancer, that prefers dark skinned people. Why are tattoos permanent? Because the ink goes into the dermis. Remember, the epidermis is epithelial and it sloughs off approximately in a month. But they're going to inject these dyes into the dermis to make it a permanent thing. Technology is improving on getting these guys off. So, you know, you had a boyfriend named Ron, and now you have a boyfriend named David. Well, good luck with that for putting the tattoo on, but I'm sure they can figure something out. Vitiligo, this is what Michael Jackson had. So it's going to be patchy melanin loss. So your melanocytes are not making packages of color anymore. They're just making little packages of nothing. And so it's the lack of color. This usually is going to spread. It doesn't usually stay in just one spot. So like Michael Jackson ended up having multiple spots. Okay, subcutaneous layer. I've actually already kind of talked on this. Underneath the dermis, you're going to have a fatty layer between their dermis, so your connective tissue proper, and let's say muscle underneath. And that's going to act as a reservoir for energy. It's going to be padding. It's going to be an insulation for heat. And it's going to be a place where we often inject drugs. So it used to be called a hypodermic syringe. Now, I don't know if they still call it that, but that was an old term. Now we just call it a syringe. But a lot of injections get put in the subcutaneous layer, hypodermis. So hypo below dermis. Women generally have a thicker subcutaneous layer than men. That's just the way it is, especially in the breasts, the rear end, hips, and thighs. Although as men get older, they do have a tendency to get some more subcutaneous fat layer, especially in their belly, and some people in their arms and their neck. Aging is a bummer. And I say that this is at the end of almost every system that we do, because as we get older, things just don't work like they used to. We don't have as good replacement of our skin cells. We don't have as good of lipid production. So our skin starts to get a little bit drier, itchier because of that. Our collagen and elastin the fibroblasts don't produce those fibers as well anymore. So we start to get wrinkles, and that area actually just, the dermal layer gets a little thinner. Also, as we get older, just like I mentioned in the mitosis section, sometimes things are more likely to go wrong with DNA replication, protein synthesis, and there starts to become some boo-boos, and sometimes with boo-boos, you get cancer. Hair, epidermal derivative, starts to get thinner. Ways to delay aging. Take good care of your skin with sunscreen. Even if you're darker in color, wear sunscreen, because that's going to prevent any damage. Good nutrition. So make sure that you're eating a balanced amount of all your nutrients like you're supposed to, like the USDA plate says. Fluids, lots and lots and lots and lots of water. Water makes up so much of our body. So drinking lots of water helps delay any of the wrinkles. And then, of course, take care of your skin. Keep it clean. Try to do your best to prevent infections or treat acne, things like that. The end.